Good morning, good afternoon, and good evening to everyone joining us from around the world. Welcome to the Future of Oral Health Transformative Initiatives, a collaborative webinar between the American Dental Association and the World Federation of Public Health Associations. This is hosted in celebration of both Global Public Health Week and National Public Health Week. My name's Kiran Nagdev. I'm a dentist and I'm a PhD candidate in epidemiology at New York University School of Global Public Health. And I have the privilege of serving as co-vice chair of the World Federation of Public Health Associations Oral Health Work Group. This session today is rooted in themes of this important week. For National Public Health Week, we have promoting health equity by recognizing diverse cultural and social contexts and reimagining global health strategies to build a fairer, healthier future. For Global Public Health Week, we're looking at the theme of the future of public health starts here, strengthening the public health workforce. Now, it is my absolute pleasure to introduce Abiola, who serves alongside me as co-vice chair and is also the incoming chair of the Oral Health Work Group at the Federation. She will offer our welcome remarks. Abby, over to you.
Thank you very much, Kieran. Hi, everyone, and a very warm welcome to you all. Introduce me. My name is Abiola, and I am the Vice Chair and incoming chair of the Oral Health Working Group of the World Federation of Public Health Association. It's my honor to welcome you to this timely and important webinar that is being held during the National Public Health Week in the United States and the Global Public Health Week worldwide. Our gathering today is with a shared purpose. We want to spotlight one of the most widespread and yet most overlooked public health challenge of our time, oral health. It affects more than 3.5 people globally, yet it's often on the margins of the health system. That needs to change. Our session today, titled Future of Oral Health Transformative Initiative, is a milestone. It's our first formal collaboration with the American Dental Association that has been a cornerstone of the oral health leadership for more than 160 years, and the WFPHA, which is a consortium of global public health initiatives, professionals from more than 100 countries. Together, we are bridging clinical excellence and public health vision. This conversation could not be more timely because in the last week, there have been major shifts in the US and in many other countries that have highlighted how dynamic and urgent it is that we achieve our quest for oral health equity and integration. At this time, we're being called not just to respond as professionals, but as advocates for justice, access, and innovation. Our themes for the National Public Health Week, the future of public health starts here, that focuses on workforce strengthening in the US and reimagining global health strategies that emphasizes equity and inclusivity on a worldwide scale is powerful. When we started planning this webinar, we didn't predict all the changes that would currently unfolding, but we're here today. These changes really highlight the urgency and the possibility of today's conversation. I'd like to extend my heartfelt gratitude to WFPHA team and to Dr. Kessler, who made today possible. I would especially like to thank Kiran, who has really put in a lot of time to make this collaboration come to life. And to everyone joining this session, I'd like to thank you for being a part of this important movement. I invite you to imagine and help build a future where oral health is no longer an afterthought, but a pillar of public health for all. Welcome. Kiran, over to you.
Thank you so much, Abby, for your kind and inspiring words. Now, it is my honor to introduce our speaker, Dr. Brett Kessler. Dr. Brett Kessler, a general dentist in Denver, Colorado, is the president of the American Dental Association. Dr. Kessler has held several leadership positions within the ADA. He served as a delegate in the ADA's House of Delegates from 2008 to 2019 and has been a consultant to the Council of Dental Wellbeing Advisory Committee from 2007 to 2018. He also served as the vice chair of the Council on Dental Benefit Plans. In 2010, he received the ADA's Golden Apple Award, which is the highest award bestowed by the association for outstanding leadership and mentoring. Dr. Kessler served as president of the Colorado Dental Association from 2014 to 2015 and was instrumental in the formulation and implementation of an adult Medicaid dental benefit in Colorado. Dr. Kessler speaks nationally on well-being and leadership topics to help dentists live their best lives. He has received fellowships from the American College of Dentists, the International College of Dentists, and the Pierre Fauchard Academy. He has testified before both the US Congress and Colorado State Legislature in an effort to help enact laws that serve the profession and the public. He graduated from the University of Illinois at Chicago College of Dentistry in 1995. He completed his general practice dentistry at Northwestern Memorial Hospital in 1997, and he's an accomplished endurance athlete and competes in events across the country. Dr. Kessler has been married to his wife, Gina Kessler, D.D.S., MS, since 1995, and together they have 4 children. Before we begin, a quick housekeeping note. Please use the Q&A feature to submit any questions you may have for Dr. Kessler, and we'll hold a dedicated Q&A session at the end of his presentation. Dr. Kessler, we're so glad to have you here today. The floor is yours.
Thank you, Karen. Thank you, everybody, for making this happen and for gracing us with some of your time today. And hope that what I'm going to talk about will lead into some great conversations and hopefully inspire you to think a little bit bigger on what dentistry could possibly be. I am the president of the American Dental Association, and that is my job. That's who I get paid from, and that's all I have to disclose. And the ADA is one of the largest oral health care professional organizations in the world. We feel we have an obligation to drive the profession forward, and we are the biggest lever in our country to move things. I always say that if we are to be thought leaders, we must provide thoughts. And so that's what this is all about today. So as Karen mentioned, I did a general practice residency, basically hospital dental program at Northwestern. And then I moved on to Flint, Michigan. And when I was in Michigan, and then from Michigan, I moved to Colorado. And in Colorado, I opened up a practice that was 100% fee for service. So I was not involved in any insurance provider networks. Patients came to see me. They paid cash out of their pockets for the services I provided. I had a whole health approach. Most of that was formulated in my general practice residency, and we'll talk about that in a second. But I had a very robust referral network of people within the dental profession and people outside of the dental profession. So back in my residency, I was seeing a very sick patient who had bacterial endocarditis around 2 valves, and she was scheduled to get those valves replaced. But she had an infection of unknown origin, and so they sent to dentistry, and I took some X-rays, did an exam, and saw 2 teeth that were pretty badly infected. One of the teeth I took out. When I took it out, pus came out with the extraction, and my attending said, "Quickly culture that pus. Let's see what it is." And it turned out to be strep viridans, the exact same bacteria that was creating the vegetations around the heart. And so I learned about medical, how the mouth was connected to the body in dental school, and here I am in my residency, and that day it was solidified that the work that I do can really positively affect the overall health of the patients I'm serving. In my practice, as I said, I had some it was kind of high-end clientele, I guess, is the best way to describe it. One of my patients was a cardiologist, a well-known cardiologist in the southwest part of America. And he created a cardiology symposium. Rocky Mountain Cardiology Symposium was what it's called. And he asked me to present to the cardiologists about medical dental integration and how can dentistry help outcomes in medical and stuff like that. And so I talked about sleep dentistry, I talked about diabetes, and then I found this article in the journal Circulation. And this article basically said that they did a study of patients who were undergoing cardiac catheterizations. They had blockages in their cardiac arteries, and so they were catheterizing them, opening up, removing those, or expanding those blockages, putting stents in so that those arteries would remain open. And so 8 out of 10, 7.9 out of 10 of those patients had strep viridin in those cardiac blockages. 8 out of 10. And I asked if the cardiologists knew of this study. They all shook their head yes. And I asked them, what do you do about that? If 8 out of 10 of your patients have strep viridans in this plaque, do you see that as a problem? And I said, though, that, I fully aware that the strep viridans, so strep viridans only lives in the mouth and in the nasopharynx. It should never be anywhere else in the body. Okay. And for it to be somewhere else, that's a problem. I stress the fact that I know the strep viridans didn't cause the blockages of the cardiac arteries, but it definitely contributed to the inflammatory process, which further shrunk the intimas of those arteries. Everybody's shaking their head, and they understood that it was contributing to the problem. So what do you do about it, cardiologists? And they say, well, we screen them. What does that look like? Well, if we see any infection, we'll send them to the dentist. And we know medical training has very little dental oral health training. And so I showed them a picture of a nice smile, and I asked them, does this look like a good smile? Is this something that you would send for screening? Oh, no, it looks good. And then I took some cheek retractors and retracted back the cheeks, and I showed them there was a draining fistula around number 3. And I asked them, what do you think that is? And one of them said, I think it's a pimple. And is that a problem? Well, we don't know. And so then I showed them an X-ray of that tooth with a periapical radiolucency, basically an infection that's evident on the X-ray. And I showed that's a fountain of bacteria that's entering into the bloodstream. That's an infection. And let's just call the spade a spade. And the reality is that you as cardiologists, first of all, don't have the training, you don't have the knowledge, and you don't have the equipment to adequately assess a patient for their dental care, their dental health. But yet 8 out of 10 of your patients have strep viridans around your plaques. And so why don't you send them to the dentist? And it really came down to that we are paid on a different payment model. The dental benefit model is much different than the medical insurance model. Okay. I also talked about how the mouth and and systemic interplay, in high blood pressure, cardiovascular health, diabetes, obesity, dementia, Alzheimer's, pneumonia, asthma, low birth weight, premature babies. All those play a part in oral has an oral component that can really help the overall systemic. Okay. And so this is a very shortened version of my presentation, so I'm kind of flying through things, but I think we all agree that the mouth is connected to the body and oral health is essential to overall health. So that patient that had the bacterial endocarditis around her heart valves, had the dental part not been, we've not been there, they would have replaced those valves, but the source of the infection is still there, and the likelihood of those new valves being infected were very, very high because we didn't remove the source of the infection, and that patient would have died. Absolutely, we were essential in the success of that patient. Absolutely, and so if we are essential, let's look at this. I'm going to shift paradigms here, but why has it been culturally accepted that in medicine, if you had a degenerative joint disease in your hip, you can get a titanium post placed there to replace it? Why is it culturally accepted that dentistry can't do that? We can get a titanium post in our hip, but we can't get one in our mouth. Okay. Why is it that medicine has been afforded the opportunity to provide its finest care to all patients in this case? And no matter what kind of dental benefit or what kind of medical benefits they have, whether it's private medical insurance, whether it's Medicaid, which is insurance for the poor demographics, Medicare, which is benefits for the older demographics, senior citizens. Okay. All benefit systems. If you have any benefits, you can get the finest medicine has to offer, yet we can't do that in dentistry. Why is walking any more or less important than chewing, removal of infection in the mouth, or smiling? Why have we allowed that to be? If we were to transfer the dental benefit model to the medical model and you had degenerative joint disease on your hip, we wouldn't give you a hip replacement, we'd give you crutches, because that's what a flipper is. That's what we've been culturally accepting of, that we don't get to offer our finest care to our patients. That doesn't sound like essential health to me. Okay, back when COVID hit, our government came and said, hey, we've got this virus, we're not sure what it is, we're not sure how dangerous it is, we're scared that our hospital systems will not be able to meet the demand of those that may need to go on respirators. We know the virus lives in aerosols, and we know you in the dental field produce aerosols, so we're going to shut you down. And we said, hey, wait a second, just because there's a virus around doesn't mean dental disease will stop progressing. And we need to be available to our patients, especially for urgent care and emergency care. And so we talked our way back into the game, and we figured out and established our place in the oral health, in the overall health delivery system. Okay, and right then and there, we deemed ourselves essential, and we did our part in lowering the curve. The bottom line is that we know how to manage infection control better than any other specialty in medicine. Okay, if you worked in the hospital in any way, shape, or form, 35% of you got COVID. Okay, less than 3% transmission in the dental office, and even that I think is pretty high. So we did our job, we did really well, and we declared ourselves essential right then and there. So now we're 5 years away from COVID, but yet we're still not considered essential. Back when the Affordable Care Act was enacted in 2014, dentistry was talked about, and children's dental care, pediatric dental care, was deemed essential. So no matter as a child where you grew up, who you grew up with, what your status was with socioeconomic and income, you were afforded the opportunity to get dental care. Okay, adults were left off that, and at the time we were very happy about that because me personally, I had this fee-for-service practice, and I didn't want the government intruding in my practice and telling me what I can and can't do and how much I can charge. And so I was very happy at the time, as we were as a profession. But looking back, I think we missed an amazing opportunity to really establish ourselves in the way the future trends are going. Okay. And because of the Affordable Care Act, so these are just some slides, some graphs that show downward trends. It basically is the amount of caries in children, okay, over time. And after the Affordable Care Act, we've improved children's dental health greatly in all socioeconomic demographics. Okay, and the bottom line is wherever we put time, effort, and money, we see improvement. And in today's current environment, where we're removing some major milestones that are predictable in science to lower caries rate is going away, and that's very scary to me. Okay, in adults and seniors, it has not gotten better. In many cases, it has gotten worse in all demographics. So same thing with seniors, it's got even worse. So the bottom line is, where we put our time, effort, and money, we see improvements. Where we've ignored, we see worsening, and that's proven. Okay, continued policy decisions on essential dental health. Our CMS has, established the Medicare Advantage plans, and that is for seniors. It's an adjunct, but only if you can afford it. And we found that it has not really helped decrease the burden on disease. Okay, CMS in November 2023, Dr. Natalia Chalmers, who I consider the dental czar of America, saw in our Medicare statute. Remember, Medicare is a benefit plan for senior citizens. Okay, in statute it says there will be no payments for dental unless it's deemed medically necessary. Okay, but that medically necessary has never been accurately defined or extensively defined. And so Dr. Chalmers decided, let's define it and get more coverage. And so they asked the American Dental Association, they asked several of the dental organizations in our country, what would you like to see if you can get benefits for medically necessary? And so we ended up getting things like cardiac valve replacements in the case that I showed before, pre-radiation dental care, organ transplants, and so we started getting to see benefits in there in that realm. Okay, and we've been working really hard on expanding it, and then actually describing a comprehensive dental benefit in the Medicare space. Okay, and in the meantime, working our best to strengthen and grow the Medicaid system. The Medicaid system in dental, especially for adults, is always vulnerable when the economy turns. And right now, we've never been more vulnerable in the history of America and dental benefits. So I'm very, very worried about this, and we're working like crazy to keep what we have and hopefully grow it. Getting more people into a dental home. In order to do that, we need dental insurance reform, both on the private side and the public side. We need to expand coverage outside of just what typical dental is right now. I'll defer that in a second. And we need to walk the walk on mouth-body connection, that the work we're doing affects the overall health of our patients. That's what essentialism is, okay? This slide, basically, the key part of this slide, and this is, I think, very important for the public health world, okay? In 2023, the dental economy had grown by $4 billion, okay? All of that growth happened in the Medicare and Medicaid space. There was no growth in the private insurance space. Everything happened in public health. 3 billion of that happened in Medicaid, 1 billion of that happened in Medicare. Because of the work we did, there was zero in Medicare prior to it. Okay, so we see the biggest opportunity for growth in the public health space. Okay, in America, we treat about 175 million patients every year, which sounds great. Unfortunately, that is only 50% of our population. 50% of our population either cannot or does not access dental care. And if we are to be successful as a profession, we need to find ways for the other half of America to access. And we think the biggest opportunity for that is in the public health space. I'm going to quickly go through that. The dental insurance model that we have currently in place is not really insurance, and many of us know that. 95% of us here in America take a dental plan. We all hate it, but we all take it, and it's worked for us for a long, long time, and it's beginning to not work for us anymore because the reimbursement rates have not increased to the level that of cost of living and the CPI. In addition, the dental insurance model that we have is, let's say there's a $1,500 max that they would pay, and they would pay 100% of preventative services. They would pay 80% of like minor dental services, like minor restorative fillings, scaling and root planing, things like that, and 50% of major services, so crowns, dental surgeries, and things like that. When we get to the 50 percentile, we as a profession are not very good at providing value enough where patients will pay money out of their pocket, and it becomes too cost burdensome, and they go away. And so as a result of that, less than 6% of people who have dental benefits of a $1,500 max ever reach their maximum. 94% do not maximize this benefit plan. This benefit plan is designed to not work. It's designed to not be accessible because of the 50% range. We know, we've done modeling that the 100%, 80%, 50% is a problem, but if we shifted that 100%, 80-50 to 100%, 80%, 80%, utilization would go way up. And so we're pushing for that change and to increase access in the private sector. Okay, so but we got to reinvent the model of dentistry. Okay, the payment model doesn't work. Okay, when I started my training outside of my residency, I studied with Pete Dawson, who's one of the godfathers of occlusion in modern dentistry, but he challenged us to be physicians of the masticatory systems. Okay, he said, don't just drill and fill teeth. Look at everything that's involved. Look at the muscles. Look at the bone. Look at the periodontal health. Look at the jaw joint and where it's seated, and look at everything comprehensively. And if you get everything balanced, equilibrated the bite, get everything balanced with the jaw in a happy place, all of your patients' problems in their life will go away. He really felt and believed in that. And I did a bunch of balancing of the bite, a bunch of equilibrations and a bunch of reconstructions and things like that. But about 25% of our patients didn't get better. They still had parafunctional problems and they still had headaches. And so we started looking deeper, and we saw that, hey, we see airway problems, and, sleep apnea then became a thing that we look at in dentistry. And because we're in the mouth, we can assess it pretty easily and do screenings for that. And so dentistry started exploding into that realm of medicine. One, because medicine recognized that we can help our patients with making appliances that moves the lower jaw forward to open up that airway ever so much, so the patient may not have to be on a CPAP machine, and improve the overall life of this patient. And so the medicine invited us to this, and dentists loved it because we found a way to get paid for it. Okay, I hate to say it, but we are a economy-driven profession. We must get paid for the work we do in an appropriate way, and this was an easy way for us to build our practices and help our patients. So that was our first real foray into the medical dental integration. Okay, but the current business model that we have with the payment system that we're in is that our drill must be spinning, or we must be scraping something to get paid. We do not get paid for consultative services. So, if I do a filling on a patient who is a smoker, has horrible oral hygiene, may use drugs, has parafunctional stress, that filling is not going to last very long. Okay. But yet if I do all these, motivational interviewing, these consultations to get the patients to change their behavior, my filling will last much longer if I can, be a catalyst for change for that patient. But we don't get paid for it. Medicine gets paid for those kind of conversations. Dentistry doesn't. We must reinvent and expand our model. Okay. And what if we can change the system to reward the dental team by preventing disease and keeping people healthy, as opposed to procedural based drill spinning, scraping, and really show that we're improving the lives of our patients. And so it's a very exciting time. We should always get paid for the procedures we provide. We are a surgical-based model, but shifting it from a surgical-based model to a management of chronic disease-based model, and basically integrating ourselves into the primary care delivery model, because I, as a dentist, can do screenings like A1C screening. I can do bleeding time INR. I can do genetic testing and oral microbiome testing. I can do these motivational interviewing opportunities. And I did it in my practice, but I never got paid for it. Okay. And I tell you, if we had benefits that paid for A1C testing, pretty much every single patient in our hygiene chairs would get an A1C test. Okay. Patients come to the dentist in a preventative mindset. Mostly, they come for their cleanings and checkups. Patients do not go to their physicians for physicals. So we've got this opportunity to do these screenings and get them to their physician for different things. In my practice, we would do scaling and root planing on patients with periodontal disease, and a certain percentage of them we'd bring back 6 weeks later, and they didn't get better. They were still really inflamed, but they had no plaque or tartar on their teeth. It wasn't a bacterial problem causing this. This was a host problem. So my hygienist would ask, tell me about your diet. Tell me about your stress level. When was the last time you were at your physician? And we sent them to their physicians, and many of them came back as undiagnosed diabetics. And those are patients for life for me now. Okay, they say I saved their lives, and in essence we did by that screening. So we've got this opportunity. So this model has been growing in the private practice realm, the fee-for-service realm. We're seeing it in the DSO realm, where some DSOs actually have physicians and dentists under the same roof practicing in private benefit systems. Okay, and you are the masters of this. This is where I learned it the most, in the public health realm, the FQHCs, the safety nets. Okay, there's an FQHC in my neighborhood in Colorado called Clinica, and it serves a predominantly Hispanic population, and 2/3 of the males above 50 are diagnosed diabetic when they come for their checkup in this FQ. And the FQ then immediately sends them over to the dentist on the other side of the hallway for periodontal screenings and dental screenings, because we know if we can get the periodontal health under control, the sugar control, the diabetic control is much, much more predictable. And so you are the masters of this, and you're blazing the trail on this new evolution of where dentistry is going. Dental schools have already made the transition. They're teaching this, but when they get out, the benefit model, separates it. Okay, technology can be a huge lever in improving access. We can get more people into the chair cheaper and more efficacy, and we need to leverage technology for that to happen. Okay, so I'm going to kind of plow through here, and we need to get back basically, our stake in the essential healthcare delivery system. We declared ourselves essential, and it's time for us to start acting like that. We can't be conveniently essential in time of a pandemic. Our vision at the ADA is to empower dental profession to achieve optimal health for all. It doesn't say optimal oral health, it says optimal health. Okay, and this has been our vision for decades. Our mission is to help dentists succeed and support the advancement of health of the public, not the oral health, but the health. So, and the bottom line is we make people healthy. So I'm gonna just put my contact information there, and I welcome questions. So thank you very much, Karen.
Thank you so much, Dr. Kessler. We do have a couple of questions, and we have more questions from our participants. So somebody asked, are there any available fellowship programs for international dental students to shadow you and learn from a great professional?
Well, thank you. That's very humbling to hear that. No, there are not. I'm not in practice right now with my role as president of the ADA. I am on the road all the time, but I am happy to talk about this kind of stuff one-on-one. I mentor a lot of young dentists and dental students. I'm very passionate about this, and if I can inspire you to explore this and get out in the field and do it, I am all in. So please email me and we can figure out a time to talk.
Okay, thank you so much, Dr. Kessler. And Dr. Deborah Weiss-Fuse is here. She's
Hi,
asked,
Deborah.
She says, thank you for this focused presentation highlighting the issues involved with medical dental integration. In your opinion, what are the most difficult barriers that need to be overcome to achieve full integration, which would clearly create a healthier population?
So I live in Colorado, and I love the mountains, and I love climbing mountains. I love running mountains. This is a mountain bigger than anything I've ever done. Okay. We've got so many barriers to this. First, within our own organization, our current payment model, our current business model is what's comfortable to us as dentists. And when we start talking about integrating medical screenings into dental offices, our dentists, our professions becomes very uncomfortable. So we need to do an education motive to get people to look at this. We see the younger dentists are much more into this because that's how they were trained. Okay. The payment system, both on the private side and the public side, is grossly inadequate, and it's very difficult to change these or to evolve these programs. But I can tell you, we are in discussions with some medical insurance plans, private, to expand dentistry, a comprehensive dental benefit in their plan. They know they will lose money on the dental side, but they will save money on the medical side. And so we're exploring what that plan design looks like. So that's going to be a big one. And then the government right now is dismantling public health, unfortunately, and we need to stabilize that before we can start expanding what our scope of practice is. Medicine, although they support this in theory, when it comes down to like Medicare, there's only a certain pot of money in the Medicare allocated towards Medicare benefits. And so now if dentistry is taking a bigger role in that, they will either have to expand that pot of money in the Medicare pot, or they will take money away from the physicians, which they are not so happy about. I can list probably 15 other barriers that we are fighting, but we all know it is the right thing to do. And we need to shout it from the rooftop in the best interest of taking care of our patients in the best possible way. Thank you for that question, Deborah.
Thank you, Dr. Kessler. Then we have a few more questions. Dr. Lois Gohan has asked one. She's also here.
Hi, Lois.
In light of the current uncertainty in global economies, how might oral health advocates position themselves to advance the agenda as outlined in WHO Global Oral Health Action Plan 2023-2030?
Yeah, it's really a troubling time, as you know. The U.S. has pulled out of WHO, so we've lost our place there. We lost our voice there, so we have to use our voice in other ways. And so we're using it through the FDI, the Federation of Dental International, and as our voice in FDI. I'm sorry, in WHO. You know, the ADA had published a paper in the World Economic Forum that talks about the economic impact of poor oral health and poor oral health systems. And that's how we have seen many governments become very interested in this, because there is a significant cost to provide dental care, but there's a even more significant cost to not providing dental care. And we think the modeling that we've seen most recently, if Medicaid here goes away in our country, it will be a threefold increase in medical costs on the other side. And so when we present it that way, that to the governments around the world, that there is an economic savings and your citizens are healthier, that's the tack that we're taking right now. But I see it working, actually. At least the conversations are being had, but it is a long game, and we have to play it out with the cards that we've been dealt, and I think that's going to be our best way forward right now in the political environment we're in.
Thank you, Kessler. Yes, thank you. We have just had a few more questions come into the Q&A feature. I wonder if this is the right question for you, but if you would like to handle this. So they're asking you to please tell us about the Greater New York Dental Meeting. And is there any way ADA can get more international dentists or dental students to attend?
Not the right person to answer those questions. It's a great meeting. I highly recommend it. It's one of the best meetings in our country. And if you can get there, please. And if you get there, please say hi to me.
Wonderful. Thank you, Dr. Kessler. Then we have a couple more. One is from Jane Kumar from Pakistan.
Hi,
He
Jane.
says, thank you, Dr. Kessler, for your insightful talk. As a dental student who deeply believes in the mouth-body connection and the essential nature of oral health, I'm curious, what role do you see for future dentists like us in advocating for systemic change, such as insurance reform and better medical dental integration? How can we, even as students, start contributing to making dentistry more universally recognized as essential healthcare?
So this is where the power of organized dentistry is put into play, put into action. You need to be a part of that. You can be one voice shouting alone, or you can be a collective, shouting together and creating opportunities. I've had the opportunity to travel internationally this past year. I'll share one trip I took was to Croatia, and I met with the Croatian Dental Chamber, and the president took me around to different parts of the country, and he introduced me to the Croatian Minister of Health. And she is the one that makes things happen. And I got to share about this with her and give her ideas on how important it is. And then the Croatian Dental Society then takes over and works out implementation plans. And so that's my best advice to you. So, stand on science. We have an obligation as a profession to educate our legislators. Every country, every state has a dental practice laws that we must abide by, but no dentists are in the legislature. So we must do, as a profession, educate those people that can influence the laws to create what's best in the best interest of the communities we're serving. And that never goes away.
Perfect. Thank you. Thank you, Dr. Kessler. There's one more from Nixon Kirimi.
Hi, Nixon.
Do you encounter a problem of dental practitioners engaging in services they're not licensed to offer in the US?
That's a tough question because I'm an N of one, and so I know what I practice, and I try and practice within the scope of what I do practice within the scope of what I'm allowed to practice in. There are, we have regulations here in the U.S. that are probably more restrictive than other places in the world. And and especially in the research realm, that I think a lot of foreign or international entities can do research in different ways than we can in America. So I can't really comment on that, but I say do what's in the best interest of your patient. If you feel confident as a practitioner in that realm, then do your best. Okay, if you're outside of the scope of your practice, then you're taking a risk, and it could be a risk that pays off, but it could be a risk that it could devastate you too. So be careful.
Okay. Thank you. I think we can do one other question before we wrap up.
Okay.
I think we can ask what strategies are being explored to make oral health care more affordable and accessible in low-income countries. This is from one of our registrants.
So the FDI has a public health committee that is working really hard to provide access. Dental care is different in industrialized nations than in some of the non-industrialized nations, and so this committee is working really hard to raise the level of dental care in the areas that are limited access. Dr. Elizabeth Schick here in America, I think, is the vice chair of that program. I know her. I don't know who the chair is, but I know she's the vice chair, and she is so passionate about this. She's always traveling to different countries. I also know that many countries and many dental schools, international dental schools, are looking for the accreditation that we get in America, and by doing that, it raises the level of the education in that area. And if it raises the level of education, it raises the level of the providers of what they can provide to their citizens. So we are working on that. It's a slow process. I apologize, but it is something that is very near and dear to all of us, that everybody has access to proper oral health care.
Thank you. I actually received one other question. Maybe we should take this as the last one. Someone's asking, what's your take on AI in dentistry? Is AI going to displace future dentists?
So I'll share, I kind of glanced through this in my presentation. In our country, we are at 90% capacity. Okay, even though we're not seeing half of America, if we found benefits for everybody, we would not have the capacity to treat the patients in our current model. Okay, and so we need to find ways to increase our capacity. So we're producing more dentists. We have a dental therapy model that is starting to take hold around the country, and then you know, encouraging all practitioners to practice to the scope of their license, the scope of what their training was in the hygiene world, especially. Okay, but then technology. Okay, can technology improve the care that we're delivering? Absolutely. When I first started practicing, I had film X-rays and I had dip tanks and technology. You know, I would go into a dark room and do what I call a 7-minute meditation because I had to wait 7 minutes in the dark to get my film. You know, and then I was one of the first dentists in my city to do digital X-rays, and now all of a sudden I had instantaneous and much better quality X-rays that I can work with. Okay, so technology is a driver of efficiency and efficacy. Okay, and so AI now, I could tell you that AI is going to be a big part of every aspect of our lives. Okay, in dentistry, we're seeing it right now as an enhancement to help us read radiographs better and help to, you know, show our patients what's most vulnerable in their mouth. Okay, but I look at AI as, what if we can use AI as the most amazing digital assistant you could ever imagine. So let's say I've got a little earphone in my ear, okay? And I would be in operatory 2, going from op 2 to op 3 to see the next patient. As I'm walking into op 3, my AI assistant's telling me, Mrs. Jones is in op 3. She was here 6 months ago for her cleaning. You did 2 fillings on her. One of the fillings was sensitive. She came for 2 adjustments, and we haven't heard from her since. She's got 3 kids. They went to Disneyland, and they've got a dog named Spot. Okay, as I'm walking into the room, this is the kind of thing I would type into the patient's chart, because had a very relationship-based patient base or practice model, and I would have to run back to my office, find the chart, find that note, and then, you know, and then I'd walk in and act like I remembered all this, but really because I documented it. So what does that do to enhance the trust of the patient? It accelerates it immensely. Wow, Dr. Kessler remembered this. That, what a great thing. I trust him is basically what happens. And so we can use it as an accelerator of trust and enhance what I consider the sacred cow in dentistry, the doctor-patient relationship. And so it really can be, it should be an enhancement if we use it right. It also will help us with our business systems and running our practices. And then it will help us with designing of what we're creating for our patients with crowns or, you know, occlusions and, you know, aesthetics and all these things that will help make us more efficient and more efficacious. It's an exciting time for AI. I'm excited about it.
Well, thank you, Dr. Kessler. We actually have a lot more questions pouring in, but I encourage everyone. Would you like to take a couple? Because
If it's okay with you.
Yes, certainly. Okay. Is the basic package of oral care created in 2003 with no update still relevant for resource-constrained countries? That's our next question.
Okay, I'm not sure what the basic level of care is, but I can tell you, I will say that we do not have a minimum standard of what good oral health is. Okay, in the cancer world, if you had cancer, the minimum standard for cancer treatment is 0 cancer cells. Okay, in dentistry, we don't have a basic minimum of what the minimum standard is for oral health. Okay, and in my opinion, so in Medicaid systems, and Medicaid systems are the benefit systems for the poor socioeconomic demographics in our country, and every year our state budgets, the Medicaid systems are challenged and vulnerable, because we don't have a way to sell our return on investment for this system. Okay, you know, how do we tell it was a successful year? Your investment of $70 million in Medicaid dental health paid off. And the way we count it, it could be patient encounters, millions of patient encounters, the number of sealants we've placed, the reduction in ER visits for dental reasons. That's a marker. But the bottom line is we don't have a unified minimum standard. And I feel that minimum standard should be free or very, very low infection or inflammation. There should be an adequate amount of teeth that you can chew with, and there should have a smile that you can, that is complete, that you can face the world with dignity. I think those three things need to be a part of the minimum standard of dentistry.
Wonderful. Thank you. I think I have one question.
Yes, ma'am.
Thank you. How do you see the role of dentistry evolving within the wider public health system, both in the US and globally?
I think in the next 10 to 20 years, dentistry will once again be a key contributor in the primary healthcare delivery system. Okay, we are so short on primary healthcare providers in our country, and we've got this opportunity to fill that void and really help our patients become healthy. That's where I see it going.
Thank you again, Dr. Kessler, for your generous insights and commitment to advancing oral health for all. To everyone who joined us today, thank you for being part of this important conversation. We hope this inspires you to think boldly about the future of dentistry, health equity, and collaboration across systems. On behalf of the ADA and the World Federation of Public Health Associations Oral Health Work Group, thank you again, and we wish you a wonderful Global and National Public Health Week. Take care and see you next time.
Thank you, everybody.
Thank you.